All right. Good morning, everybody, and welcome to our renal physiology cadaver dissection lab. We're going to go over a couple things, a little bit of line items for today. You're going to have three exercises. I've already uploaded them for your Blackboard. So exercise 1 is going to be the cadaver dissection that we're going to do together on the dot cam. And then exercise 2 will be actually going through the nephron and completing a worksheet with that, and I'm going to show you that right here. And then exercise 3 will actually be a virtual histology, so you go on the link that I have attached and you look through those histology slides, okay? So yeah. So first of all, the part of the nephron. So the nephron is a functional unit. It is the cell of the kidney, and your nephrons, on average, each kidney, a healthy patient, has about 1 million nephrons, and that degeneration of these nephrons could cause kidney disease, the sloughing off of it from any kind of chronic inflammation, infection. So these are the main structures of the nephron. You've got your afferent arterial and efferent arterial. I remember A means going towards it, and E as in exit. So the afferent arterial goes into the glomerulus, and then the efferent arterial leaves the glomerulus, okay? And then from that, you've got your Bowman's capsule and Bowman's space, and that's where a lot of your filtration occurs through diffusion. You have certain things that go through the nephron and things that get preserved in your blood. And then from that is your proximal convoluted tubule, your descending loop of Henle, ascending loop of Henle, distal convoluted tubule, and the collecting duct, okay? So let's get into that right now. So first, the nephron contains, the kidney has your renal cortex and your renal medulla. And so the cortex features have renal corpuscles, proximal and distal convoluted tubules are mainly in your cortex, whereas in the renal medulla, you got your loop of Henle as well as your collecting duct, so the tubule portions. Of course, when we dissect it, you'll notice that your renal cortex is actually lighter than your renal medulla, and that has to do because when we learned about with blood, the brightness of the blood, the bright red is because of the heme component. So there's more vasculature in your renal cortex with the arterioles and the convoluted tubules. So there's more blood there, so which is why it appears lighter in dissection, whereas your renal medulla that contains mainly your loop of Henle and your collecting duct is going to be primarily darker in appearance, and you'll see that for our dissection. So you've got, most of your nephrons are cortical nephrons, and then you've got these juxtamedullary nephrons. So the cortical nephrons, they have short loops of Henle that mainly stay in the cortex. So then the main thing you've got is your collecting duct tubules that are in the medulla. But then you've got about 15% of your nephrons that have the juxtamedullary nephrons, which means the loop of Henle, descending and ascending, juts into the medulla, okay? And it's essential for mainly water resorption and urine concentration is the main roles of your loop of Henle. So the further down the loop of Henle, which I'll show right here, as it descends, it becomes more and more concentrated because water's leaving. And then as the loop of Henle ascends, it becomes less and less concentrated. The urine actually becomes more dilute because now osmolarity, the solute, is leaving, okay? And then the collecting duct, that's where it becomes more concentrated, which is why you get your yellow pee, because more water's leaving. And we'll get into that. So first, when it comes to your microscopic structures of the kidney, your nephrons are microscopic and only visible under a microscope, which you'll see for your histology lab, but they mainly filter blood. And the main functions of your nephron are not just for filtration, but reabsorption of certain water, electrolytes like sodium, and then secretion of waste such as ammonium, okay? And then additional roles, it plays a role in blood pressure, so the more water reabsorbed and sodium that we reabsorb. And something you need to know is water follows sodium. So when we say that sodium is getting reabsorbed into the bloodstream from your nephron, that means water's following it, so it's going to increase blood volume and therefore increase your blood pressure, okay? And then red blood cell production, we learned in blood unit that EPO, erythropoietin, is that protein that's produced in the kidneys that helps stimulate erythropoiesis. So this is where that comes into play. And then you've got calcium absorption through the parathyroid hormone, and it's activated through vitamin D. So those are some main roles, like some very key roles that the kidney does that you need. Your renal corpuscle mainly has the glomerulus and the Bowman's capsule, so those are definitely going to be in your renal cortex. And the glomerulus has a capillary bed, which if you see in the diagram here, that's the glomerulus with the capillary bed. And that's where, again, the afferent arterial blood goes in, and then it gets filtered. All the excreted waste to go into the Bowman's capsule, and then whatever stays goes out through the efferent arterial. And then the Bowman's capsule is what captures that filtrate, and then it proceeds on to the proximal convoluted tubule. So you've got fenestrated capillaries, podocytes, and a basement membrane as your filtration membranes, and you'll learn that more in lecture, but it's just important to know that the Bowman's capsule is actually made of simple squamous epithelium. So that tissue is used, it's a permeable membrane, so it's good for diffusion. So that shows, again, that the Bowman's capsule is able to take in that solute, that filtrate, so that it can go on through the nephron. And there's selective filtration. So large nonpolar molecules, for the most part, are not going to go through the nephron. So things like albumin, which is your protein that's located in your plasma of your blood, or certain nonpolar substances, large substances like glucose, those are not supposed to go through your urine, mostly. Now, if we have a damaged urine due to things like, for example, preeclampsia, one of the main things you see there is proteinuria, which means albumin has passed through the Bowman's capsule and is present in your urinalysis, okay? And yes, repels negative charges, so positive charges will go through, like sodium, your potassium will go through. And this is that fenestration slits that I was showing you right there. And then the basement membrane. So for juxtaglomerular apparatus, you've got the macula densa, which is what monitors your sodium levels and flow rate in the distal convoluted tubule, which is after your loop of Henle. So it releases ATP and adenosine as signals. And then for the juxtaglomerular cells, their main role is to contract and relax to adjust to your GFR, which stands for glomerular filtration rate. So we actually use glomerular filtration rate to measure how efficient your kidneys are functioning. If you have a low GFR, which is associated with a high creatinine, that means you are probably in kidney failure, depending on how low it is. And actually, if it's severely low, patients are usually put on dialysis because they're in chronic kidney failure. And then if they're in kidney failure, we put them on the transplant list at a certain number. And that's called a GFR-eGFR equation, is how we calculate that. And also your juxtaglomerular cells will release renin. That starts the RAS pathway, which is renin-angiotensin-aldosterone system, okay? And the renin-angiotensin-aldosterone system is a cascade of events where renin's released to promote angiotensin 1, that then transfers to angiotensin 2 to release aldosterone. And when it releases aldosterone, that is what reabsorbs sodium. And like I said, sodium, water follows sodium. So if we reabsorb the sodium in your filtrate, you're also reabsorbing water. So what that means is aldosterone actually increases your blood pressure. And you'll see that mainly in your juxtaglomerular cells, so near the glomerulus, okay? And it's important you know where your hormones are working. And again, water follows sodium. Another thing I want to point out, and all this is happening in your glomerulus, right? There's another hormone called atrial natriuretic peptide that we learned in cardio. So that actually decreases blood pressure by releasing sodium. So it is an actual antagonist of aldosterone, okay? And it's important to know that. Now for the proximal convoluted tubule, the main thing is it reabsorbs your solutes. So it'll reabsorb like sodium, chloride, and glucose. It's lined with cuboidal cells and microvilli for that brush border lining. You also see a brush border in your intestines, the brush border enzymes that we talked about. And it has a high mitochondria count. And of course, mitochondria, the main role for that we learned in GI is mitochondria are used to make ATP, which is why we learned mitochondria is the powerhouse of the cell, right? It's the battery of the cell. So it's mainly for reabsorption of solutes. And anything that it doesn't reabsorb, it'll like send out in the filtrate. And it's important that glucose and albumin are going to be reabsorbed in the blood for a normal, healthy patient. A patient that is possibly sick with some type of disease, you might see albumin, so proteinuria, or glucoseuria, which is like fruity smelling urine, which is present in diabetic patients. So that's why we take a urinalysis, because whatever is present in their urine is very important to understand so that you can help diagnose the patient. For the loop of Henle, you've got a descending and ascending limb. So let me go back to, I know I keep going back and forth, but I just want to show a visual. Your descending limb goes down, descending, going down. And your ascending goes up. Your descending limb is right after the proximal convoluted tubule, okay? And it is water permeable and then solute impermeable. So what I mean by that is water permeable, as in water can enter, exit freely. And through what's called a countercurrent exchange, water leaves the nephron. And as it's leaving, it leaves more and more as we go down. So the units of measurement of solute concentration for your urine is in milliosmoles per liter. The normal is like about 300 milliosmoles per liter in your body. We'll talk about that with total body water next week. But 300 milliosmoles per liter. As something becomes more concentrated, like when I say more concentrated for urine, I'm talking about yellower, darker, more odorous urine. That's something that has increases solute concentration. So from 300 to 400, 500, 600, 700, all the way down to at the bottom of the descending loop of Henle is 1200 milliosmoles per liter. So is that really concentrated? Yes, it's very concentrated, like very, very concentrated, because a lot of water left. Now the ascending loop of Henle is water impermeable, but solute permeable. So that means water's not going to leave, but the solutes will leave. And when they leave, then it becomes less and less concentrated. So from 1200 milliosmoles to 1100, 600, 500, all the way up to 300, all the way up to 100 milliosmoles per liter actually. And then you get more water that gets reabsorbed with sodium at your distal convoluted tubule, and then more water gets reabsorbed right here at the collecting duct, and that's why you get that concentrated urine. And on average, it's around your urine, if you want to know like what's the average concentration, it's about 700 to 900 milliosmoles per liter. If it's more than that, it means you need to drink some water. If it's a lot less than that, it means you already drink a lot of water. So, and this is that RAS system I was talking about. So it happens in your juxtaglomerular cells, located in your afferent arterioles near the glomerulus. So this renin-angiotensin system, this is the flow chart that I love about it. So first, the kidney releases an enzyme, renin, into your blood, and the liver releases angiotensin in the blood because of that, which becomes angiotensin 1. That then angiotensin converting enzyme, it's called ACE. So you ever heard of like ACE inhibitors? For like cardio, we'll go back to that. But again, ACE is what promotes angiotensin 1 to become angiotensin 2. And then that causes widespread vasoconstriction, and then it stimulates the adrenal cortex to secrete aldosterone, because that's where the aldosterone hormone is located. It's in the adrenal glands, which is on top of your kidneys. And once aldosterone gets secreted, sodium gets reabsorbed, which means water gets reabsorbed. So let's go back to what I was talking about with cardio. Like I said, the body is a beautiful machine that connects so well. So for aldosterone, for angiotensin converting enzyme known as ACE, because it converts Ang1 to Ang2 to stimulate the adrenals to release aldosterone, to therefore reabsorb sodium, to reabsorb water in the blood, that increases what? Aldosterone would increase your blood volume because it's reabsorbing that water in the bloodstream, therefore increasing blood pressure. So an ACE inhibitor, if we give for our cardio patients, that would decrease blood pressure because it stops the conversion from Ang1 to Ang2. Does that make sense? So just teaching a little bit of pharmacology too, like this is where it matters. I jumped ahead. So distal convoluted tubule, those are made of cuboidal cells. Again, I'm always important to know the histology, and have fewer microvilli and fewer mitochondria, so not as much ATP as before, but you're still getting that ion active transport, and it fine-tunes that ion balance. So it's gonna, reabsorb sodium, secrete potassium, hydrogen ions, so it's kind of fine-tuning that. And then by fine-tuning that, it brings in more water. It's kind of bringing in more water in your system to keep you hydrated. And then there's continued reabsorption and secretion, which is sensitive to aldosterone in that RAS system, okay? That's why that RAS system is so important in our kidneys. And then the final part of your nephron is the collecting duct. So the collecting duct is the last site where we reabsorb water. So you see these channels right here behind me? Oh, let me hide. See that channel? That's a channel in your cell membrane, and it is a water channel called an aquaporin, because aqua, water, get it? And it's a pore. So the role of it is when the aquaporin channel opens, water leaves the collecting duct to go back to your blood. And if it goes back to your blood, it's going to increase blood volume, therefore increase blood pressure. So it also increases your blood pressure, just like aldosterone. Not just like, because it's a different mechanism, but it increases blood pressure by what's called antidiuretic hormone. You remember that from endocrine? So antidiuretic hormone, which is secreted from your posterior pituitary, what it does is it turns on those aquaporin channels. And when it turns on the aquaporin channels, water exits the collecting duct to go back into your bloodstream to increase your blood pressure, okay? And so that's the important. If you have no antidiuretic hormone present, then your aquaporin channel is not going to turn on. And if it doesn't turn on, that means that water is not going to go back into your bloodstream. And if water doesn't go back into your bloodstream, that means that your blood pressure is not going to go up. But it also means that water is going to instead be in your urine, which is why you get that dilute urine, okay? Now, if aquaporin channels turn on, water is going to enter your bloodstream, increase that blood pressure, but also means you're going to get more concentrated, more yellow, odorous urine, okay? So that's how the ADH works. And then it only allows water passage. There's 6 types of aquaporin channels in the kidneys, and it's mainly essential for that water balance, okay? And remember, ADH is also called vasopressin, okay? Antidiuretic hormone, another name for that you'll hear in the hospital is vasopressin. So we actually have vasopressin that will push for patients to increase their blood pressure, okay? Hemodialysis. Hemodialysis is an artificial unit that helps filter your blood, and you go on dialysis if you're in kidney failure. We have a lot of dialysis centers throughout the country because of this, because they increase the diabetes occurrence, increase of chronic kidney disease. But what it does is it actually, your blood leaves into the system, gets filtered and spun, and the waste materials are left behind, and you get clean, healthier blood that goes back into your system. And basically, it acts as an artificial glomerulus because, again, we study your EGFR, your glomerular filtration rate. If you have failing kidneys, you have a damaged nephron and therefore a failing glomerulus. So this kind of substitutes that by acting as your artificial glomerulus, okay? All right. Well, let's get started, okay? So first, it's important to get situated to where you are located. So here we have our kidney, and like I said, this is a pig kidney, so it is about half the size of your human kidney. But for all intensive purposes, orientate yourself with your kidney, get to where you can see. You've got the top part, the apex of your kidney. It's called the superior extremity. So that's the tip, and that's one of the images you need. At the end, just take a photo of all this at the end, by the way, guys. But it's your superior extremity, and that's kind of where your adrenal gland sits. And that's important because, for example, the RAS system, aldosterone is secreted from your adrenals, and that helps increase sodium reabsorption and water follows sodium, increasing that blood pressure. So it's a very important structure right there. And then you've got your stellate veins, which it's kind of hard to see here, but it's this darkened region. Sorry, let me get a pen. And the stellate veins drain that superficial renal cortex and ultimately contribute to form the renal veins and venous drainage of the kidney, okay? So very important structure. Then you've got your renal vein, which it's very hard to see because there's fatty tissue covering this, but for all intensive purposes, you've got, if this adipose tissue, this structure, this connective tissue wasn't really covering, you'd have your ureter, and then your artery and vein are kind of on here. So the renal vein is on top of the renal artery, and it's smaller, and it carries blood that's filtered from the kidney into your inferior vena cava and to the heart. So it's major for like your kidney function and health, all right? And your renal artery, which is larger, and it's again covered by the connective tissue, it supplies that oxygenated blood to the kidney so that to filter that waste and excess fluid from the blood. So it supplies blood to your kidney, okay? And then you've got the renal hilum, which is kind of surrounding the renal pelvis, so it's right out here. And that renal hilum is the entry and exit site for vessels and nerves, as well as the ureter. So any type of vasculature you have, that's kind of the entry and exit points for it. And then you've got your lateral margin. I'm not going to label it, but it's lateral means side, like side to side in anatomy. So the lateral margin is actually the side margin of the kidney. And for anybody who's interested in urology and wants to go into urologic surgery, for surgery such as a partial nephrectomy, which nephrectomy means removal of your kidney, so a partial one, usually for like cancer patients, if there's a tumor, we would remove just a piece of it. A lateral margin refers to the edge or border of tissue removed. And a negative margin means that there's no cancer cells found at the edge, indicating a complete tumor removal. So it's important to know what your lateral margin is, okay? And then you've got your ureter. I know I'm going back here. Again, we can't see it because this connective tissue, but the ureter, that is the main portion. It's actually probably at the bottom right here, but it stems off, and its major thing is to transport urine that's from your kidneys to the urinary bladder so that it can be excreted, all right? So if you have things like kidney stones, has anybody had a kidney stone in here before? Oh my gosh, first of all, how painful is it? Yeah, it's bad, okay? It's really bad. Bless you for making it out, okay? But it's so painful, and it blocks the urine to be excreted from your ureter. And it can be, I don't know, did it have to get removed, or did it, okay, so if they're small enough, they can actually pass on their own. And when you hear that pass on their own, you're like, well, what does that mean? It means the crystallized kidney stone is able to move through the ureter painfully, but move through, get into the bladder, and then you can actually excrete it, okay, through your urethra. But again, very painful. Okay, so this is the outer structures that you have. Oh yeah, and then you have the inferior extremity. So you've got your superior, inferior. So these are some main structures that I would take a photo of. Just this right now, okay? Yeah. And this is where I pause. Sorry, I'm not going to stop it. When you're taking a photo, let me know. You good? So I haven't even had my coffee yet, believe it or not. I'm just high off these formaldehyde fumes. Let me start I'm just happy to see you guys. Your smiling faces. You guys good? Okay, cool. What I want you to do is to now make a mid-sagittal dissection. What does that mean? Yep, down the middle. Cut this bad boy in the middle, and it should look something like this. You see that? Can you guys see? Yep. Can you see that? So cut it down the middle. Take your time. I am not in a rush. I cut it in advance, and I already put everything labeled. All right, so next thing I want to get to is your medullary rays. So actually, let's start to the top. You've got your renal cortex, which is the bright gray outer exterior. So go ahead and put a pin anywhere around here. All this is your renal cortex. And like I said in the lecture, it's brighter colored because it's more vasculature, okay? There's more blood there, okay? And then you get your renal medulla, which is darker. So that's this pin right here, if you noticed. The renal medulla is darker because it's not as vasculature. It doesn't have as much vasculature as your renal cortex, so not as much blood, but it mainly has your collecting duct and for your juxtaglomerular nephrons, those loop of Henle, okay, descending and ascending limbs. So it's more tubular compartments, right? But you got your renal cortex, your medulla. Well, your medulla is right here. This division, the medullary rays, are bundles of tubules and blood vessels that extend from the cortex into the medulla to facilitate that substance exchange. And it plays a crucial role in urine concentration, okay? Another thing I want to point out, you see this little fatty hole right here? It contains like adipose tissue. So that's the renal sinus. It contains fat, and it cushions and protects the kidney's inner structures, such as the renal pelvis, the calyces, which you're going to get to, the blood vessels, and the nerves. And it serves as an entry and exit point for these structures. This is your renal sinus, okay? Sinus is in a hole. Then you've got your renal columns, which are an extension of the cortex. So you see how you got your cortex? Your renal columns extend into the cortex. So you see them right here. Like this or this. These are your renal columns. And so as you see how these medulla make these pyramid shapes and there's like lines in between them? Those are the renal columns, the lines in between, because they are extensions of your renal cortex that divide the kidney into 6 to 8 lobes by separating renal pyramids. Remember I said pyramids? And act as a supportive framework for those blood vessels. So now you've got your papilla of the pyramid. So like I said, you have your medulla, which is right here, which makes this like triangular shape. And at the bottom of it is the papilla. So the papilla of the pyramid is what collects urine, and it actually sends it to your minor calyces, which are right here. The minor calyces are always at the bottom, by the way. So minor calyces, this is not minor calyces, but this is your minor calyces. And the role of the minor calyces is they collect urine from those papilla of the pyramid, and it sends it to the major calyces, which are at the top right here. And those major calyces then send that urine to the renal pelvis, which is right here, that collects that urine and then sends it off to the ureter, which is down here, okay? And then that ureter sends that urine to the urinary bladder to be excreted, okay? A thing about the renal pelvis, so kidney stones will actually begin to form in your major calyces and or your renal pelvis, and they can block the ureter. And depending on how large or small they were, you're saying yours were small enough. But if they're large, like too large to pass, like they are completely blocking the ureter, no urine can get out, and they can't even pass through because the ureter is very tiny, as you see. See how narrow that is? If it's too large, then we do a surgical removal, which is called a percutaneous nephrolithotomy, PCNL, or a uteroscopy. It's a minimally invasive surgery. We go in and we just excise that kidney stone, okay? Now, parts of the nephron by location, because I think when you know where it is, you are able to attribute the important parts of the nephron. So first, in the renal cortex, which I said is the lighter version, that's where mainly your proximal convoluted tubule and your distal convoluted tubule, that's where they are, and your glomerulus and Bowman's capsule, okay? So those beginning structures, your glomerulus, your Bowman's capsule, Bowman's space, your proximal convoluted tubule, and your distal convoluted tubule, right? And again, that makes sense. There's more blood in the glomerulus because of that capillary bed. So that's why it's lighter, because it's more vasculature. And then when we get into your medulla, which are these darker regions, that's where the loop of Henle is for your juxtaglomerular cells. So your descending and ascending limb. And then also your collecting duct, regardless, is going to be in your renal medulla, specifically within those renal pyramids, okay? And the renal cortex, like I said, is more vascular. About 90% of blood is in your renal cortex, which shows, because see how bright that is? 90% of your blood's there. And about 10% is in your renal medulla. The renal medulla is darker than the cortex because it contains more renal tubular structures. So when we're talking about with blood, remember hemoglobin that makes up your red blood cells? It's a tetramer and contains heme. And that heme is what gives a red pigment when oxygen gets to it, which gives that bright red color. So again, the more vascular, the more bright you'll see it. So the more vasculature, more blood is in your renal cortex. So that's just kind of connecting the why for that, okay? So that is all of the structures that you have to go through. Are there any questions? Okay, you need to label this and take a photo of this. And you're done. Yeah, I told you that was quick. A lot quicker than the heart.